بسم الله الحمد لله والصلاة والسلام على نبينا محمد وعلى آله وصحبه وسلم. Inshallah, today our lecture is about the pharmacology of the respiratory system. And the respiratory system is one of the systems that controlled by the autonomic nervous system. So that after we cover the first, the autonomic nervous system, then we'll talk about the respiratory, GIT, and cardiovascular. All of these mainly depend on the autonomic nervous system. As you know, that the functions of the respiratory system is to enable or to perform the breathing process. Breathing process is the exchange of oxygen and carbon dioxide on the bronchioles. Also, the respiratory system enable the speech production. As you know, the anatomy of the respiratory system consists of upper respiratory tract, which include the nose, mouth, pharynx, epiglottis, larynx, and trachea, and the lower respiratory tract, which consists of the bronchial tree and the lungs, two lungs. Regarding the pharmacology of the respiratory system, we will talk inshallah about the following drugs which affect the respiratory system. First, the anti-asthmatic drugs that used for treatment of bronchial asthma, acute phase and late phase of the asthma, either allergic or non-allergic asthma. And decongestants, the drugs are the drugs that used to relieve nasal congestion. And usually this is, as we know from the pharmacology of the autonomic nervous system, consists of sympathomimetic agents, exactly alpha-1 agonists such as phenylephrine, nafazoline, xylometazoline, and other alpha-1 agonist selective agonists. Expectorants, these are drugs that used to facilitate the expectoration. Expectoration means the elimination of the mucus in the patients that suffer from productive cough with mucus, while the antitussive agents are drugs that use to relieve the dry cough, and usually these are centrally acting agents. And last, we have mucolytic drugs. These are drugs that lead to breakdown of the mucus, the polysaccharide, sulfide bonds, polysaccharide in the mucus breakdown, so that also can facilitate and enhance the lysis and expectoration and relief of the mucus. Also, we have drugs that used in treatment of tuberculosis and antibiotics that used to treat the tuberculosis, the infectious disease, which is a challenging infection caused by the mycobacterium tuberculosis. Also, we have, inshallah, in the next lecture, inshallah, we'll talk about the treatment of tuberculosis. The autonomic regulation of the respiration, as we mentioned previously on the autonomic nervous system, you will find that especially beta 2 receptors, beta 2 adrenoreceptors are abundantly. A lot of beta 2 receptors are expressed on the human airway smooth muscles, as well as mast cells, also epithelium and gland and alveoli. So that the beta agonist activation will activate this receptor, resulting in relaxation of the bronchial smooth muscle, inhibition of the mediator release such as histamine from the mast cells, and increase mucociliary clearance. The overall effect is to promote and facilitate respiration by this mechanism. While the parasympathetic innervation of the bronchial smooth muscle also occurs through the muscarinic receptors, which mediates bronchoconstriction and mucus secretion. So that, as we know, atropine can be used pre-anesthetic and pre-operative to clear the bronchial secretion, to clear the bronchial secretion, and to promote the airway flow of the air through the airways. Now we'll talk about the bronchial asthma. Bronchial asthma, as you know, it is a recurrent, reversible obstruction of the airways in response to stimuli. These stimuli are not themselves noxious and do not affect non-asthmatic person. It only affects the asthmatic person. Non-asthmatic person, these stimuli will not affect them. Asthmatic patient experience an intermittent attacks of wheezing, صفير يعني فوق wheezing, shortness of breath, dyspnea, and difficulty, especially in breathing out, and sometimes with cough. These are symptoms of asthma. This is a normal bronchial tube on the left, normal bronchial tube, in which you will find that the muscle of the bronchi are relaxed, allowing easy airflow, while in case of inflamed bronchial tube, we'll find muscle and bronchi are tight and thickened, thickness, there is thickness, and the bronchi are inflamed and filled with mucus, which impedes airway flow, which impede air flow, which impede or obstruct air flow. Asthma can be either allergic asthma or non-allergic asthma. Allergic asthma is the type 1 hypersensitivity reaction. You know the hypersensitivity reactions from the pathology. Actually, the allergic asthma is type 1 hypersensitivity reaction, in which antibodies, immunoglobulin E antibodies, are sensitized by the B cells and attached to the surface of the mast cell, and when there is an allergen, will lead to will attach to these immunoglobulin E antibodies, and this will lead to the release of mediator from the mast cells such as histamine and leukotrienes and other cytokines, which can lead to the bronchoconstriction and symptoms of asthma. In case of allergic asthma, attacks occur in sensitized individuals where an allergen interacts with immunoglobulin E antibodies, leading to histamine release and other mediator release, such as I mentioned, cytokines and leukotrienes. Actually, the allergic asthma prevalence is about 30% of the overall asthmatic patient. 30% of these patients, of asthmatic patients, are allergic asthmatic patients. Allergen, as we mentioned, bind to specific immunoglobulin antibodies, leading to deregulation and release of mediators such as histamine, prostaglandin E2, leukotrienes D4, and leukotrienes C4. Here is a typical type 1 allergic reaction, type 1 hypersensitivity allergic reaction, in which the allergen, such as a ragweed pollen, for the first time, when it detected by the beta cells, the beta cell will synthesize immunoglobulin E antibodies for this ragweed pollen, and this will attach to the surface of the mast cell. On the second time, when the person or an individual exposed for the same pollen, which is detected by the B cells, directly this allergen will bind to immunoglobulin E that occur on the surface of the mast cell, and leading to the activation of this mast cell, releasing the chemicals or mediators such as histamine, leukotrienes, prostaglandin D2, which is responsible for the characteristic symptoms of allergy, such as allergic asthma. Non-allergic asthma, in this case, an irritant such as chemicals, coal, or drugs, or even allergens, some allergens, or pollutants, and even in case of infection, stimulate the irritant receptor. Here directly an irritant stimulate the irritant receptor. Differ from the allergic asthma by that the allergic asthma, as we mentioned, is a type 1 hypersensitivity reaction in which it involves interaction with immunoglobulin E antibodies, leading to the activation and release of the mediators that is responsible for the allergy and asthma. Here, directly the irritants stimulate the irritant receptors which occur in the respiratory epithelium. This leads to the release of mediators which activate the mast cells and other cells because of the inflammation changes in the airways in sensitive asthmatic patient. This leads to hyper responsiveness or hyperreactivity, leading to reversible airways obstruction, leading to the asthma symptoms. Asthma can be classified into two phases. The immediate phase, which is an bronchoconstriction, immediate bronchoconstriction, occur abruptly, suddenly, due to the spasm of the bronchial smooth muscles, and the cells that involved are the mast cells, but other cells also can contribute to the immediate phase, such as the platelet and macrophages. This is the immediate phase, immediate bronchoconstriction. The second is the late phase, which is an inflammatory reaction, which occur at variable times after exposure to the stimuli. maybe nocturnal. طلعت من الصباح وانت ازمتك الجو كان فيه غبار، بعدين بالليل بالمساء تجيك ازمه اتاك nocturnal. Late phase, so it is a late phase because it's an inflammatory reaction. It takes a time, variable times, maybe hours, 2 hours, 3 hours, 8 hours, 12 hours. It's an acute inflammatory reaction, as we mentioned. These two phases are very important because regarding the pharmacology, so that we have drugs that selective or drug of choice for the immediate phase, and other drugs are effective for the late phase of the asthma. We have aspirin sensitive asthma. Aspirin sensitive asthma, as you know, that aspirin is one of the non-steroid anti-inflammatory drugs, and aspirin can precipitate asthma in some individuals, some sensitive individual. Actually, here rare, but it represent about relatively here uncommon, and represent less than 10% of asthmatic subjects, less than 10% of overall asthmatic patients whom عندهم aspirin sensitive, whom are aspirin sensitive or have aspirin sensitive asthma. Now we'll talk about the pharmacology of the drugs that used for treatment of asthma. There are two categories of anti-asthmatic drugs. The first one are bronchodilators, which are very effective and are drug of choice for the immediate phase of asthma, bronchoconstriction. And the anti-inflammatory agents, which can prevent the components of two phases, the late immediate phase and the late phase. Bronchodilator reverses the bronchospasm of the immediate phase, as I mentioned, while the anti-inflammatory agents inhibit or prevent the inflammatory component of both of phases. Some drugs are classified as bronchodilator and also have some anti-inflammatory effects. We'll see. First, we'll talk about the bronchodilators. The main drugs that used as bronchodilator are first beta-2 agonists. We know these beta-2 agonists such as salbutamol, salmeterol, terbutaline, formoterol. And the second group of drugs, methylxanthine, such as cephalin, aminophylline, caffeine, all of these are methylxanthines. And third group of drugs are leukotriene receptor antagonists. Leukotriene receptor antagonists, leucast, such as monteleucast and zafirleucast. as we know, leukotrienes are the one of the inflammatory mediators. So these drugs, by blocking the receptor of leukotrienes, can prevent the bronchoconstrictions that mediated by leukotrienes. Also, we have muscarinic receptor antagonists such as ipratropium and tiotropium. We know that vagal stimulation through the muscarinic receptor can stimulate the bronchoconstriction. So by blocking the muscarinic receptor, we can provide bronchodilation. Bronchodilation is promoted by the increase by the second messenger through cyclic AMP. So that the increase in intracellular levels of cyclic AMP is the main trigger for bronchodilation, and this can be occurred by or stimulated by beta 2 receptors, because beta 2 receptors stimulate adenylate cyclase, as we know that. And also can be the increase in the endogenous cyclic AMP concentration can be promoted by the phosphodiesterase inhibitors such as cyphylline and aminophylline, because this enzyme phosphodiesterase stimulate the breakdown of the cyclic AMP. So by inhibiting this enzyme, we can increase the level of the cyclic AMP. So this is we have bronchodilation, as we mentioned, is promoted or stimulated by the second messenger, who is cyclic AMP, and the cyclic AMP is increased due to the enzyme of adenylate cyclase from ATP, converted ATP to the cyclic AMP, and this can be stimulated. Adenylate cyclase can be stimulated by beta 2 agonists. All of the beta 2 agonists, beta 1, beta 2, beta 3, all of these beta receptors lead to stimulation of the adenylate cyclase, leading to increase in the cyclic AMP. cyclic AMP after formation is breakdown كليفج، يتكسر السايكليك، تتكسر بواسطه الانزيم اللي هو الفوسفودايستريز، يتحول ل AMP، يعني السايكل الرينج يحصل لها كليفج، تتكسر. This enzyme can be inhibited by methylxanthine such as cyphylline. By inhibiting this enzyme, we can increase the cyclic AMP and increase the bronchodilation. While bronchoconstriction is promoted by acetylcholine through a muscarinic receptor, as we mentioned, and this can be inhibited by muscarinic antagonists such as atropine, and actually we use ipratropium and tiotropium. Also, methylxanthine can act by second mechanism. This is a second mechanism for methylxanthine, such as cyphylline, because it inhibits adenosine receptor, A2 receptor, because adenosine as a mediator, by acting on an A2 receptor, this can lead to bronchoconstriction. So a cyphylline can block this receptor, here A2 receptor, adenosine receptor, A2 receptor, also can prevent the bronchoconstriction. So as we mentioned that bronchoconstriction can be inhibited by muscarinic antagonists such as atropine, ipratropium, tiotropium, and adenosine receptor antagonists also can inhibit bronchoconstriction that mediated through adenosine on A2 receptor. This by methylxanthines such as cyphylline and aminophylline. While also leukotriene receptor antagonists such as monteleucas and zafirleucas also can inhibit bronchoconstriction. Beta 2 receptor agonists, as we mentioned, they are the drug of choice for immediate phase bronchoconstriction. They dilate bronchioles by direct effect on beta adrenoreceptors, and they inhibit the mediator release from the mast cells, as we mentioned before, and also may inhibit the focal tone, and this last effect can be considered as adverse effect. The example for beta 2 adrenoreceptor agonist, as we mentioned, we have salbutamol and terbutaline. Salbutamol and terbutaline are short-acting. They can be given by inhalation, aerosols, or nebulized solution through nebulizer, and also can be given orally in the form of tablet, or by injection in emergency for acute bronchospasm. We have also long-acting beta-2 agonists such as salmeterol and alformoterol. These are long-acting beta-2 agonists. Muscarinic receptor antagonists. As we know, they are competitive antagonize acetylcholine mediated bronchoconstriction on the muscarinic receptors of the bronchial airways. They also decrease the vagal stimulated mucus secretion. The main compounds that used as bronchodilator are ipratropium and tiotropium. Mainly we use ipratropium, but also tiotropium is available. It is longer acting. This is tiotropium مقارنة بالإبراتروبيوم هو longer acting and used in maintenance treatment of chronic obstructive pulmonary disease. Combination of both an anticholinergic, antimuscarinic, and beta agonist may be helpful in patients who have inadequate response to a single inhaled bronchodilator. بعض المرضى ما استجابوا لبيتا 2 agonist alone، نديهم in combination، ندي معاهم muscarinic antagonist. Methylxanthines. By the way, methylxanthines pharmacologically are classified as CNS stimulant drug. So more details about methylxanthine will be studied inshallah in the pharmacology of the central nervous system. They are CNS stimulant. But we know that methylxanthine are bronchodilator and act by two mechanisms producing bronchodilation, by inhibition of phosphodiesterase and by inhibiting adenosine receptor. They include natural occurring methylxanthines such as seiphylline, theobromine, and caffeine. Also, we have a synthetic one called aminophyllene, synthetic methylxanthine. Seiphylline has been largely replaced with beta-2 agonists and glucocorticoids because that, or due to that, seiphylline has a narrow therapeutic window, narrow therapeutic index. Also have a wide profile of adverse effects, including GIT symptoms, nausea, vomiting, diarrhea, abdominal pain, and CNS effects such as restlessness, nervousness, and shaking. All of these are adverse effects of seiphylline. And potential for drug interaction. Also, seiphylline has high potential for drug interaction. Any drug interaction either will increase seiphylline leading to toxicity or decrease the concentration of seiphylline leading to the absence of effects. Seiphylline overdose may cause serious and potentially fatal arrhythmias. So this is a toxicity or overdose of seiphylline. We have a leukotriene receptor antagonist. We know that all the leukotrienes, leukotrienes C4, leukotriene D4, and leukotriene E4, all of these leukotrienes act at the same high affinity on leukotriene receptor, which is termed as LT1, leukotriene receptor 1. We have two types of receptor, leukotriene LT1 and LT2. They act on LT1, producing bronchoconstriction. We have a drug that ends with leucas suffix, with leucas such as monteleucas and zafirleucas, antagonize only the LT1 receptors. So they reduce bronchoconstriction and inflammatory cell infiltration that is mediated by the leukotrienes. Also, we have a group of drugs called 5-lipoxygenase inhibitors, drugs that inhibit the enzyme 5-lipoxygenase. And this enzyme 5-lipoxygenase is the enzyme that is responsible for the synthesis of leukotrienes from the arachidonic acid. Arachidonic acid, the 20 carbon atom acid that mobilized from the membrane phospholipids, lead to this, or many inflammatory components are derived from this acid, arachidonic acid. This include the icosanoids, prostanoids, prostaglandin, and the thromboxanes, and the leukotrienes, different types of leukotrienes. All of these are derived from the arachidonic acid. From arachidonic acid, the enzyme 5-lipoxygenase is synthesized the leukotrienes. So the inhibition of this enzyme by a drug, we have a drug called Xileuton. Xileuton is the 5-lipoxygenase inhibitor. So this can inhibit the synthesis of leukotrienes from the arachidonic acid. It relieves bronchoconstriction from exercise. We found that Xileuton effective in relieving the bronchoconstriction that arise from exercise. May have liver toxicity because it can alleviate the liver enzymes. It inhibits the microsomal B450s, means that Xileuton may lead to a drug interaction by inhibiting this microsomal enzyme, cytochrome B450. This can inhibit the metabolism of many drugs, and this can lead to drug interaction. Now we'll talk about the corticosteroid, glucocorticoids, which are powerful and effective anti-inflammatory agents that can be given prophylactically. They inhibit the late phase and they decrease the inflammatory cell infiltration into the airways and also inhibit the edema formation. They include diclomethasone, budesonide, fluticasone. All of these 3 drugs can be given by inhalation. Also, we have a prednisolone, which can be given orally for treatment of asthma. This example for inhaled glucocorticoids that use diclomethasone, budesonide, and fluticasone, and triamcinolone. Also, these can be used as anti-inflammatory agents either for asthma or chronic obstructive pulmonary disease or for allergic rhinitis. Inhaled corticosteroids are the drug of choice for the long-term control in patients with any degree of persistent asthma. Their mechanism of action: corticosteroids inhibit the release of arachidonic acid through the inhibition of the phospholipase A2 enzyme. Phospholipase A2 is an enzyme that leads to mobilization, freedom of the arachidonic acid from the endothelium membrane phospholipids. From the phospholipids, the enzyme phospholipase A2 lead to mobilization of the arachidonic acid, and we know that the arachidonic acid, from this arachidonic acid, all of the inflammatory mediators, the eicosanoids, the leukotrienes, and the prostaglandins are synthesized from this arachidonic acid. So by inhibiting the enzyme phospholipase A2, we will inhibit the mobilization of the mobilization of the membrane phospholipid, and so we'll inhibit the formation of the arachidonic acid, and so we will inhibit all of the synthesis and formation of the other inflammatory mediators, including leukotrienes and prostaglandins. Thereby producing direct anti-inflammatory properties in the airway by inhibiting this inflammatory mediator, an earlier step in the production of these inflammatory mediators. After several months of regular use of corticosteroids, inhaled corticosteroids, this will reduce the hyperresponsiveness of the airway, smooth muscles, to a variety of bronchoconstrictor stimuli, such as allergens, irritants, cold air, and the exercise. Side effects of corticosteroid. Actually, corticosteroids have a lot of adverse effects, a lot of side effects. This include decreased growth in children, osteoporosis, increased appetite leading to weight gain, hypertension, and emotional disturbances. Sometimes in some patients, euphoria. Others may experience depression. Increased risk of infection because corticosteroids are immunosuppressant, will inhibit the immune system, leading to increased possibility for infections. Glaucoma, increased intraocular pressure, and centripetal distribution of the body fat, circular or around fats around the body. Increased risk of diabetes because they are hyperglycemic, tend to increase blood glucose, may lead to the actual diabetes, development of actual diabetes in susceptible individuals due to the chronic use of corticosteroids also can lead to hypokalemia, serious adverse effects, and edema, peripheral edema also can be developed due to the long-term use of corticosteroid. We have also chromolene sodium, also called sodium chromolylate, and nitochromyl sodium. These drugs are known as mast cell stabilizers because they prevent histamine release from the mast cell. They prevent the histamine release from the mast cell, so they are traditionally called mast cell stabilizers. Although they are very safe, but they have only weak anti-inflammatory effects and short duration of action. So they give them prophylactically. They reduce both immediate and late phase of asthmatic responses and reduce bronchial hyperreactivity. They are received only for prophylaxis, and they have weak anti-inflammatory effects compared with corticosteroids. These are the guidelines for treatment of asthma according to the classification of asthma. If asthma is classified as intermittent, intermittent means the bronchoconstrictive episode is less than 2 days per week, less than 1 or 2 times per week. This is classified as intermittent asthma, and we will find the result of peak flow or spirometry near to be normal. Here there is no need for long-term control, so there is no daily medication of long-term control, while we will find in each asthma attack or in each asthma classified asthma, in case of the immediate phase, rapid relief of the symptoms for the bronchoconstriction, you'll find the drug of choice is a short-acting beta-2 agonist in all of the asthma class, in which in any type of asthma type, we will find that short-acting beta-2 agonist is the drug of choice to relieve the or to provide rapid quick for the relief of the symptoms. Short-acting such as salbutamol or terbutaline. In case asthma is classified as mild persistent, and in case of mild persistent, we'll find more than 2 episodes of attack, bronchoconstrictive attack, will occur per week, and we find the result of peak flow near to be normal. Here we need to have long-term control with low dose of inhaled corticosteroid, such as budesonide, diclomethasone, or fluticasone, or whatever corticosteroid, inhaled corticosteroids. Also, if the asthma is classified as moderate persistent, and here in case of moderate persistent, we will find that the bronchoconstrictive episodes occur daily, and result of peak flow is about 30 to 80% of the normal. Here we need long-term control, either by low dose inhaled corticosteroid or long-acting beta agonist, such as salmeterol or formoterol, or we need medium dose instead of low dose plus long-acting beta agonist. We can use only medium dose of inhaled corticosteroid. Last, if the asthma classified as severe persistent, and we find that the bronchoconstrictive episode in case of severe persistent is continual, and here we'll find the result of peak flow is less than 30% of the normal. Here we need either medium dose of inhaled corticosteroid plus long-acting beta-2 agonist, or we use high dose of inhaled corticosteroid plus long-acting beta agonist. This is a guideline according to the American. This is an American guidelines for treatment of different classes of asthma attacks. Now, finally, regarding treatment of asthma, we will talk about the severe treatment of severe acute asthma, which is an state of asthmaticus emergency that involves rapid hospitalization and rapid treatment with drugs. Severe acute asthma is a medical emergency that requiring hospitalization. And treatments include oxygen and in high concentration. Also, the patient need to be inhaled with salbutamol given by nebulizer. Also, intravenous hydrocortisone fluid, intravenous immediately, followed by oral prednisolone. Last, additional measures occasionally used include, according to the situation of the patient, according to the response. If the patient not respond well, we may need to add nebulized ipratropium, muscarinic antagonist, or intravenous salbutamol, or aminophylline. And sometimes the patient may be need to give an antibiotics if there is a bacterial infection is present in this hospitalized patient with status asthmaticus. I think that's all about asthma. Now talk about another respiratory disorder symptom here, mild symptom, mild element, rhinitis or stuffy nose. Rhinitis or stuffy nose. Rhinitis is a decrease in the nasal airways due to the thickening of the mucosa and increased mucus secretion. This is accompanied by symptoms. This primary symptoms lead to the primary symptom of rhinitis. Rhinitis also sometimes called allergic rhinitis and hay fever. Also is a type of rhinitis, seasonal rhinitis. The primary symptoms of rhinitis is the nasal dripping. Nasal dripping means rhinorrhea or runny nose. Also nasal itching and nasal congestion and sneezing. These are the primary symptoms of allergic rhinitis. Allergic rhinitis is caused by chronic or acute inflammation of the mucous membrane of the nose due to the viruses or bacteria, or sometimes due to irritant. Treatment of rhinitis include topical and systemic decongestant, and we know that both of these drugs, topical or systemic, they are sympathomimetic drugs, consist of selective alpha-1 agonists such as phenylephrine, oxymetazoline, nafazoline, ephedrine, even adrenaline. Topical, nafazoline, oxymetazoline available as topical, and systemic we have pseudoephedrine and phenylpropanolamine. This can be given systemically. Steroid nasal sprays are effective and safe and may be effective without oral antihistamine. Without use of oral antihistamine, we can use this topical, spray, nasal spray steroids such as beclomethasone and budesonide can be used as nasal spray for treatment of rhinitis. Also, systemic corticosteroids such as triamcinolone or prednisolone are effective at reducing the nasal inflammation, but their use is limited by their short duration of action. They should be used only for short duration of action because we are afraid of side effects, adverse effects that result from prolonged steroid therapy. This is Rinacort, beclomethasone, used for treatment of as nasal spray for treatment of rhinitis, and this atrovine, which consists of oxymetazoline, selective alpha-1 agonist, for treatment, topical treatment of to relieve nasal congestion. Now we'll talk about the decongestants, and we already talked about, but we can summarize these drugs. They are, as I mentioned, they are classified as systemic or topical. Systemic decongestants stimulate the sympathetic nervous system through alpha-1. They act as alpha-1 agonist. to reduce swelling because they can produce vasoconstriction of the blood vessels. They reduce swelling of the respiratory tract and vascular networks, especially the nasal blood vessels, leading to decongestion, relief of nasal congestion. They include, as I mentioned, ephedrine, phenylpropanolamine, and pseudoephedrine. It's one of the atropine. We find oxymetazoline, as I mentioned. Here we have a flow tab. We find pseudoephedrine as oral. Pseudoephedrine plus a drug called tribororidine antihistamine plus analgesic paracetamol for relief of cough and congestion. Topical decongestant when applied directly to the swollen mucous membranes of the nose, they provide immediate relief from the nasal congestion. These drugs include ephedrine, epinephrine, phenylephrine, nafazoline, oxymetazoline, tetrahydrozoline, and xylometazoline. All of these drugs are selective alpha-1 agonists. Topical decongestants act directly on the alpha receptor, as we mentioned, of the vascular smooth muscle in the nose, causing the arterioles to constrict, resulting in very little of the drug to be absorbed, and this is provide an advantage that they haven't systemic absorption, so they are free of systemic adverse effects. Topical decongestant provide two major advantages over systemic decongestant. The first one is that minimum adverse effects, because there is a very minimum systemic absorption, so they can be used, for example, safely in patients with hypertension, while the systemic ones should be used cautiously or not used contraindicated in patients with hypertension, because this systemic one should be absorbed, and this can lead to constriction of the blood vessels, leading to increased peripheral vascular resistance, and this can arise the blood pressure. The second advantage of a topical decongestant over a systemic one is that they have rapid relief of the symptoms, because they act directly topically on the nasal mucosa and the blood vessels of the nasal cavity, leading to the rapid relief, while the systemic absorption take a time, because it needs to be absorbed systemically and distributed through the blood to the site of action on the nasal cavity. So the advantages of topical is that they provide rapid relief of symptoms compared with the systemic decongestants. Pharmacotherapeutics regarding decongestants, we use decongestants to relieve the symptoms of swollen nasal membranes that resulting from a hay fever, allergic rhinitis. Systemic decongestants in practice are frequently given in combination with antihistamine, such as chlorpheniramine, or with tribororidine. Tribororidine and chlorpheniramine are antihistamine, and with this combination with antibiotic, usually we use antibiotic analgesic, usually we use paracetamol. This combination commonly occur in FlowTab, NoFlow, IliFlow, AmiFlow, CityFlow. All of these cough tablets, or all of these flow tablets consist of these three combination: decongestant, pseudoephedrine, analgesic, paracetamol, antihistamine, either tribororidine or chlorpheniramine. Also, systemic decongestant can be occur in combination with antitussive cough syrups, or with the expectorants, also the cough syrup that used to facilitate the productive cough. I think that is all regarding this the first lecture of the respiratory system. Inshallah, on the coming lecture we will continue on the respiratory system. That is all. Thank you. Assalamu alaikum wa rahmatullahi wa barakatuh.